Okay, this next topic is STI and HIV. Gonorrhea is caused by gram-negative Diplococcus neisseria gonorrhea. So gram-negative Diplococcus. To remember this, Neisseria gonorrhea infection can occur on any mucous membrane surface, typically genitourinary, but also rectum and pharynx. So gram-negative Diplococcus neisseria gonorrhea can occur in any membranous surface. The incubation period of gonorrhea is 2 to 5 days, so very small incubation period. Typical symptoms would be urethral discharge for male, dysuria, cervicitis for female, vaginal discharge, low abdominal pain. It can also be a rare cause of heavy menstrual period, postcoital or intermenstrual bleeding. So something which keeps on coming in the question: postcoital bleeding, vaginal discharge, abdominal pain, discharging from urethra. Rectal and pharyngeal infection is usually asymptomatic, but many may present as rectal bleeding. 50% of females are asymptomatic, whereas asymptomatic infection rarely occurs in males. Due to this asymptomatic nature, complicated gonococcal infection is more common in women than in men. Local complications that may develop include urethral strictures, epididymitis, and salpingitis, hence may lead to infertility. So inflammation can be there. Disseminated infection may occur severely. Okay, so gonococcal urethritis is among the most common cause of Bartholin gland abscess, which cause pain and swelling. Symptomatic gonococcal urethritis typically present with penile discharge and dysuria within 2 weeks of exposure. Okay, so diagnosis can be microscopic examination of gram-stained smears. 95 to 95% sensitivity for males, and 37 to 50% sensitivity for endocervical smears, and 20% for urethral smear. So the one which gives you the best diagnosis, NAT, nucleic acid amplification test, more than 96% sensitivity in both symptomatic and asymptomatic infection. Use of NAT is superior to culture for extragenital sites. Culture is cheaper and allows confirmation, identification, and antimicrobial susceptibility testing. Routine testing for chlamydia trachomatis should be carried out in all adults with gonorrhea, since co-infection is common. 35% of heterosexual men and women, 41% of women with gonorrhea. Okay, management would be uncomplicated anogenital infection in adults. Ceftriaxone 500 mg IM as a single dose, plus azithromycin 1 gram oral as a single dose. So it's uncomplicated infection. Patients should refrain from sexual intercourse till they and their partners have completed treatment. This will be 7 days after the treatment was given. Okay, so ceftriaxone 500 mg IM and as it's 1 dose. In pregnancy, seek specialist advice. Recommended treatment of isolated gonorrhea is either cefixime 400 mg single oral dose or ceftriaxone 250 mg IM, or 3 gram amoxicillin plus 1 gram propionic orally, or ceftriaxone 500 mg, or all that. So disseminated gonococcal infection and gonococcal arthritis may also occur, with gonococcal infection being the most common cause of septic arthritis in young adults. The pathophysiology of GGI is not fully understood, but is thought to be due to hematogenous spread from mucosal infection and asymptomatic genital infection. Complications include septic arthritis, endocarditis, perihepatitis, all these. Key features of the disseminated gonococcal infection: classic triad of tenosynovitis joint, migratory polyarthritis also joint, dermatitis skin. That's the end of gonorrhea. Next is vaginal discharge. It's a common presenting symptom and is not always pathological. Common causes like physiological can be there as well: candida, trichomonas vaginalis, bacterial vaginosis. Adherent homogeneous discharge in speculum examination. So less common cause can be cervical infections such as chlamydia and gonorrhea can cause discharge. There is rarely the presenting symptoms. Ectropia and foreign body cervical cancer. Okay, so what the conditions, what kind of discharge is there? Candida, C. So cottage cheese discharge, C. Vulvitis, itch. So there will be cottage or cotton candy, whatever the way to remember. Okay. Um, Trichomonas vaginalis. So Trichomonas vaginalis, offensive, yellow green. So just remember Trichomonas, the color of green. Trichomonas, offensive, yellow green, frothy discharge, vulvovaginitis, strawberry cervix. So just remember green strawberry or Trichomonas. Tricky green strawberry. So tricky green strawberry. So offensive, yellow green, frothy discharge, tricky green strawberry. Vulvovaginitis, strawberry cervix. Okay. Bacterial vaginitis is offensive as well. Both are offensive. Thin, white, gray, fishy. Bacterial discharge. So fishy discharge. So just remember fish. Vaginosis. So Trichomonas vaginalis, if you remember, this candida, this cottage cheese discharge, vulvitis, and H. And Trichomonas vaginalis, you will have offensive yellow greens, frothy discharge, vulvovaginitis, and strawberry cervix. Bacterial vaginosis, offensive thin, white, gray, fishy discharge. It's candida, by the way. So bacterial vaginosis describes an overgrowth of predominantly anaerobic organisms such as Gardnerella vaginalis. So this is green garden as well. This leads to a consequent fall in lactic acid, reducing anaerobic lactobacilli in a raised vaginal pH. While it's not a sexually transmitted disease, infection is seen almost exclusively in sexually active women. Amsel's criteria for diagnosis of PV is 3 of the following 4 points: a thin, white, homogeneous discharge, clue cells on microscopy. So this is something very common. Clue cells on microscopy for bacterial vaginosis. Oh, so sorry. Okay, there's a mistake. Green is just like green, yellow. Frothy discharge is not the green here. So Gardnerella is for bacterial vaginosis. In fact, this one. So there will be clue cells on microscopy, thin, homogeneous, white discharge, and vaginal pH is more than 4.5. Positive fifth test addition of potassium hydroxide results in fishy odor. So features will be the clue cell is there as well. Fishy vaginal discharge, asymptomatic in 50%. Oral metronidazole is the way to go for 5 to 7 days. Vaginosis, metronidazole for vaginosis for 5 to 7 days. 70 to 80% initial cure rate and relapse in more than 50% within 3 months. Bacterial vaginosis in pregnancy results in an increased risk for preterm labor, low birth weight, and chorioamnionitis, late miscarriage. It was previously taught that oral metronidazole should be avoided in the first trimester, and topical clindamycin used instead. Recent guidelines, however, recommend oral metronidazole is used throughout pregnancy. So BNF is against the use of high-dose metronidazole regimes. Okay, next is chlamydia. Chlamydia is the most prevalent STI in the UK, and it's caused by Chlamydia trachomatis, an obligate intracellular pathogen. Approximately 1 in 10 young women in UK have chlamydia, so it's dangerous. Incubation period is 7 to 21 days, although it should be remembered that a large percentage of people are asymptomatic. Asymptomatic in 70% of female, 50% of male. Women, cervicitis, discharge bleeding, urethritis, pelvic inflammatory disease, and arthritis. Men, urethritis, discharge, urea, proctitis, epididymitis, and arthritis. Complications: epididymitis, pelvic inflammatory disease, endometritis, increased incidence of ectopic pregnancies, infertility, reactive arthritis, perihepatitis syndrome. All these complications can happen. Okay. Traditionally, investigation Traditional cell culture is no longer widely used. Again, NAT is the investigation of choice. So previously we studied NAT is the investigation of choice for what? Also gonorrhea. So also NAT is the investigation of choice. And uh, first, void urine, vulvar vaginal swab or cervical swab may be tested using the NAT technique. So urine, vulvar swab or cervical swab. Gonorrhea would be demonstrated by the presence of gram diplococci on the swab. If the swab showed non-specific urethritis, a diagnosis of chlamydia is most likely. Both may coexist as well. So gram diplococci. So as we stated from the gonorrhea, gram negative diplococcus was there in gonorrhea. So here on the swab, if it's gonorrhea, there will be gram negative diplococci. Non-specific urethritis, the diagnosis of chlamydia is most likely. Okay. National screening program is open to all women and men. So what do you give for chlamydia? Basically give doxycycline 7-day course or azithromycin 1 gram once, then 500 mg daily for 2 days or azithromycin for 20 to 14 days. If pregnant, give azithromycin 1 gram once, then 500 mg for 2 days. Patients diagnosed with chlamydia should be offered a choice of provider for initial partner notification, either trained practice nurses with support from GUM or referral to GUM. Advise that sexual intercourse, including also, should be avoided unless the person and their partners have completed treatment for waited 7 days for the treatment of azithromycin. Men with symptomatic infection, all partners from 4 weeks prior to the onset should be contacted. Women and asymptomatic men, all partners from the last 6 months of men recent should be contacted. Contacts of confirmed chlamydia cases should be offered treatment prior to the results of the investigation being known. Okay. A test of cure should be carried out for the following treatment. Okay, so what is the treatment? 7-day course of doxycycline is the main treatment, or azithromycin 1 gram once, then 500 mg daily for 2 days. 2 days. Or azithromycin 500 mg twice daily for 10 to 14 days. For pregnant woman, azithromycin 1 gram once, then 500 mg for 2 days. Same one, just no doxycycline. Okay, chlamydia psittacosis is known as parrot disease, parrot fever, characterized by malaise fever, myalgia, pneumonia, rash, horror spot, pathognomonic, exposure to eelbird. Give erythromycin or tetracycline. Erythromycin or tetracycline are the drug of choice. Psittacosis, Sitta 6. Erythromycin. Erythromycin. Okay. Next is the STI, other STIs that are there, important ones as well. Not much left from the topic itself. Infectious disease, genital ulcers. So, genital herpes is most often caused by the herpes simplex virus type 2. Cold sores are usually due to HSV type 1, and primary attacks are often severe and associated with fever, while subsequent attacks are generally less severe and localized to one side. Other causes of genital ulcers are listed below. So genital ulcers are there. There's painful herpes. Okay, of course, herpes painful. They have painful herpes. Okay, chancroid herpes is more painful than chancroid. Okay, and painless is syphilis, lymphogranuloma venereum, granuloma inguinal. All these are painless, but syphilis is more. So herpes simplex virus, there are 2 strains of HSV in human, HSV1 and HSV2. So while it was previously thought that HSV1 accounted for old lesions, cold sores, and HSV2 for genital herpes, it's now known that there is considerable overlap as well. So just remember one thing here, you can see this diagram. HSV1 is on top, HSV2 on the bottom. So that's how you can remember that there's oral lesions and there's genital lesions 1 and 2. So features in the primary infection may present with severe gingivostomatitis, cold sores, painful genital ulceration. So herpes is painful, That's why it here is painful. It's painful ulcers, herpes. Management in healthy patients. The infection is self-limited even without treatment. Gingival stomatitis can give also acyclovir or chlorhexidine mouthwash, also topical acyclovir. Genital ulcer, genital herpes, oral acyclovir as well. Some patients with frequent exacerbation may benefit from long-term acyclovir. So, some on a note, it's like HSV meningitis or encephalitis typically in temporal lobe. Remember that. Next, coming to a very important subject as well, topic as well, syphilis. Syphilis is basically, as we've said, painless genital ulcer is syphilis. So syphilis is painless. So it's a sexually transmitted infection caused by spirochete treponema pallidum, studied before, long time. Infection is characterized by primary, secondary, and tertiary stages. Painless also chancre is seen in the primary stage. So primary is chancre. The incubation period is 9 to 90 days. That's a long time exposure. Incubation time. Chancre is painless also at the at the site of sexual contact, often not seen in women. So painless lymphadenopathy will be there. So it's all painless. Painless ulcer, painless lymphadenopathy. So it's a painless stage. Secondary would be 6 to 8 weeks after primary. So primary is like 9 to 90 days after exposure. That's almost 3 months max. And then 6 to 8 weeks after primary, that is almost 1 or 2 months. Systemic symptoms are fever, lymphadenopathy. So there's fever and lymphadenopathy, rash on trunks. Secondary. Fever, lymphadenopathy, rash on trunks, palm and soles. Buccal, snail track ulcers, 30%. Condylomata lata. Buccal snail track ulcer is there. Rash on trunk, palm and soles, and the fever is developed. This is 6 to 8 weeks after the primary thing that happens 9 to 90 days after exposure. Then tertiary can be 10 to 25 years after a primary infection, characterized by development of chronic granulomatous lesion called comata. Cardiovascular syphilis, it's aortitis, that targets the aorta with aortic aneurysms, usually in the ascending part of the aorta. Valvulitis with aortic regurgitation. So this happens a long time after that. Aortic regurgitation can be there. Neurosyphilis, general paralysis of the insane. Severe weakness and psychiatric symptoms. Tabes dorsalis, this happens in syphilis. Slow degeneration of the sensory neurons. The degenerating nerves are in the dorsal column. Proprioception, vibration, and touch. Fine touch can be affected. So this dorsal columns are affected. Tabes dorsalis happens in syphilis. Tertiary syphilis, that's like a long time after the primary infection. Taboparesis can also occur. Form of tertiary syphilis, which contains features of both taboparesis dorsalis and general paralysis of the insane. Meningovascular syphilis, meningitis, and often occurs with corneal nerve palsy and papilloedema. So treponema pallidum is a very sensitive organism and cannot be grown on artificial media. The diagnosis is therefore usually based on clinical features, serology, and microscopic examination of infected tissue. So what can you do? Serological test is the main thing. Cardiolipin test, not treponema specific, and treponema specific antibody test. So these two are there, but this one is not really specific. So what do you do exactly? So this is actually the VDRL test, cardiolipin test, VDRL. Syphilis infection leads to the production of non-specific antibodies that react to cardiolipin. Examples include VDRL, Venereal Disease Research Laboratory, and RPR. Insensitive in late syphilis becomes negative after treatment. So this one VDRL becomes, this is not really specific, so becomes negative after treatment. And TPHA, this cause of false positive cardiolipin. So this test can be positive sometimes even without syphilis. Why it can be positive? During pregnancy, SLE, antiphospholipid syndrome, TB, leprosy, and then malaria, HIV. All these can cause a positive cardiolipin test, and VDRL can be positive as well. Treponema specific antibody test is example as TPHA. Treponema pallidum hemagglutination test remains positive after treatment. So this will stay positive even after treatment. So if these two are positive together, which means patient is having the okay. So if these both are being positive here, the VDR and the TPH both are positive, means the syphilis is positive, right? And if this is negative and this is positive, which means it's already been treated, becomes negative after treatment, this remains positive. So should maybe write it down: VDRL TPHA positive disease, VDRL negative, TPHA positive, treated. So remember this too, very important. Okay, so remains positive after treatment. So long treatment of syphilis is penicillin, of course, 600 mg IM for 10 to 12 days. 10 to 12 days. Okay. For CNS disease, secondary and tertiary syphilis, the treatment regime is for 14 days. If not penicillin sensitive, tetracycline or doxycycline for 14 days. Follow-up should occur over 2 years to ensure a satisfactory response. Cardiovascular neurosyphilis, procaine, penicillin 600 mg IM for 21 days. Jarisch-Hamer reaction, release of endotoxin when large number of organisms are killed by antibiotics. It's seen in 50% of patients with primary syphilis and about 20% with secondary syphilis. So occurs about 8 hours after the first injection, consists of mild fever, malaise, and headache. And headache lasting a few hours. Prednisone can be given to reduce its effect. So what happens is like this: mild fever, malaise, headache lasting a few hours. So prednisone can be given. 3 to 40 milligrams is given in divided dose 2 to 3 days before and after the 30 milligram to 40 milligram per day is given in divided dose for 2 to 3 days before and after the first dose of antibiotics, reducing by 5 milligram the day after. It can be seen in other conditions, for example, in treatment of leptospirosis, tetracycline therapy in brucellosis, dapsone therapy in leprosy, antibiotic of Lyme disease. So all these can have this Jarisch-Hamer syndrome reaction. Okay, moving to the next one is lymphogranuloma venerum. It's caused by chlamydia as well. Chlamydia trachomatis, same as chlamydia. Same organism is causing this. So typically infection comprises of 3 stages. So I've studied there that there is genital ulcer, painless syphilis, then lymphogranuloma venerum as well. So it's painless as well. So stage 1 is small painless pustule which performs an ulcer. Inguinal syndrome, stage 2, painful inguinal lymphadenopathy. So this is painful lymphadenopathy, not ulcer. Lymphadenopathy painful. Stage 3 is regional abscess or fistula resulting in regional strictures and proctocolitis. Okay, colitis. Okay. Regional abscess or fistula. So happening in the specific region, diagnosed by serology and intradermal skin test by LGB antigen, phrase test is called. Management usually spontaneously remits but can be treated with tetracycline or erythromycin. Patients with LGB may also harbor other transmitted disorders including syphilis. Other causes of genital ulcers are Behçet's disease, carcinoma, granuloma inguinal, Klebsiella granulomatous, all this. Okay, was chancroid. Chancroid is also a painful ulcer disease also. Tropical disease caused by Haemophilus ducreyi causes painful genital ulcer shared with painful inguinal lymph node. So it's all painful. It's all painful. Chancroid is all painful. And lymphogranuloma venerum, it's painless pustule which forms an ulcer, and then there's painful inguinal lymphadenopathy. So if you remember that painful LA and this painful LA but painless ulcer here is all painful. Okay, it's all painful genital ulcer, painful inguinal lymph node enlargement. So chancre and chancroid, let's see. So the organism is Haemophilus ducreyi, and it's chancre, it's Treponema pallidum, that's in syphilis. And then non-exudative, and there's a gray or yellow virulent exudate, soft edge, hard edge, heals spontaneously within 3 to 6 weeks in the absence of treatment, can occur in pharynx as well as genitals. Okay, moving to genital warts, also known as condylomata acuminata, are a common cause of attendance at the genitourinary clinic. They're caused by many varieties of the HPV, especially 6 and 11. So especially 6 and 11 are actually causing it. It's now well established that HPV, primarily 6 types 16, 18, and 33, are predisposing to cervical cancer. The main incubation period is about 3 months. However, it's quite variable and may range from 3 weeks to 8 months. So basically, 6 and 11 is now established. No, it's like 6 and 11 are the ones which are causing problems. Okay, causing genital warts. So features are small 2 to 5 millimeter fleshy protuberance which are slightly pigmented, may bleed or itch. Biopsies indicated when genital lesions are atypical in appearance, pigmented, indurated or fixed, resistant to standard treatments, or occurs in patients with more than 40 years of age. So primarily what you do, number one, is topical portofilin or cryotherapy are commonly used as first line treatments depending on the location type of lesion. Multiple non-keratinized are generally treated with topical agents. Multiple non-keratinized are generally best treated with topical agents like topical portofilin, whereas solitary keratinized bones respond better to cryotherapy. So this is what. Second is imiquimod is an immune response modifier. Eliminates warts by enhancing cell-mediated immune pathways that target the cells harboring. Generally uses second line. So imiquimod. So first one is, as you said here, topical portofilin for multiple non-keratinized, and solitary keratin cryotherapy. Also one. Second is imiquimod. Okay, genital warts are often resistant to treatment and recurrence is common, although the majority of anogenital infections with HPV clear without intervention within 1 to 2 years. Women should not become pregnant during treatment. Okay, so yeah. So that is it for genital warts. Moving to the last topic, HIV, very important topic. HIV and its complications. All these always keeps on coming. Even past medicine, too many questions regarding this. So this topic has to be like very much clear. Okay, so HIV seroconversion or primary HIV infection is symptomatic in 60 to 80% of patients and typically presents as a glandular fever type illness. Increased symptomatic severity is associated with poor long-term prognosis. Occurs 3 to 12 weeks after infection. Some man returns from trip abroad with maculopapular rash and flu-like symptoms. Think HIV seroconversion. For questions involving businessmen, always consider STI. So yeah. Features are sore throat, lymphadenopathy, and then malaise, myalgia, arthralgia, diarrhea, maculopapular rash, mouth ulcers, rarely meningoencephalitis, concomitant STI. So this is the HIV virus with lipid membrane, this RNA capsid, GP120, GP41 reverse transcriptase. Okay. Diagnosis: antibodies to HIV may not be present. So HIV viral RNA load test may be required to confirm the diagnosis. So there are some things like HIV antibodies, ELISA, or with Western blot. HIV antibodies are positive by 4 to 6 weeks, and P24 antigen positive from first week to third week. So P24 first, maybe second is this. Anyway, management is antiretroviral therapy has previously been delayed until CD4 is less than 200. This was largely due to the toxicity of drugs and fear resistance developing. Recent guidelines now suggest treatment can be started at any CD4 count. All patients diagnosed as being HIV positive should be offered immediate treatment, irrespective of CD4 cell count. So very important. Start the treatment immediately. Commitment on to and strict adherence to treatment over many years is required. No adherence can be associated with drug resistance, progression to AIDS, and death. The treatment regimen should take into account dosing convenience, potential drug interactions, clinical symptoms, and comorbidities. Treatment of HIV infection in treatment-naive patients is initiated with a combination of two nucleoside reverse transcriptase inhibitor (NRTI) as a backbone regimen, plus one of the following as a third drug. So two NRTI, so two NRTI plus one of these three. So one of these three is what? Integrase inhibitor, like the gravirs, as we knew before, and then there's this non-nucleoside reverse transcriptase inhibitor, and then a booster PI, the Inavir or something like that, all those names. So the regimen of choice contains a backbone of emtricitabine and either tenofovir or tenofovir disoproxil or tenofovir alphenamide. An alternate backbone regimen is abacavir lamivudine. Third choice of drug is either ritonavir boosted, all of years. Efavirenz may be used as an alternative third drug. So backbone emtricitabine plus tenofovir. Patient who require alternative can be abacavir lamivudine. Patient who require treatment for both HIV and chronic hepatitis B should be treated with antiviral agents. Against both these as part of fully suppressive combination ART. Regimens of choice are tenofovir, disoproxil, and emtricitabine, and all that. HIV immunology. The following immunological changes are seen in progressive HIV. Reduction in CD4 count. Okay. The following immunological changes are seen in progressive HIV. Reduction in CD4 count. Then increase in beta to microglobulin. Increase in beta to microglobulin. Decrease IL-2 production. Polyclonal B cell activation. Decrease NK cell function. Decrease delayed hypersensitivity responses. So in progressive HIV, there will be reduction in CD4, increase beta 2 microglobulin, decrease IL-2. So CD4 and IL-2 is decreasing, and beta 2 microglobulin is increasing. These ones, all these categories you need to remember and how it works as well. But the thing itself is nucleoside reverse transcriptase inhibitor. Then there's integrase inhibitor, non-NRTI, and boosted protease inhibitor. Okay, so some important information to be added is like two nucleoside reverse transcriptase inhibitor. We know that there's mrcp, and then there's other ones like abacavir, zidovudine, and all that. All those ones are like the two nucleoside reverse transcriptase inhibitor. So the side effect is peripheral neuropathy. Integrase inhibitor like veltucravir, all the gravirs, veltucravir are there. Then NNRI is nevirapine, efinarance, inducer P450, and booster protease inhibitor, indinavir, nelfinavir, ritonavir, all the virs are inhibitors. So remember that as well. Okay. HIV and vaccination. So this occurs at variable frequency in exams. In clinical practice, I always refer to a specialist for advice for vaccinating HIV patients. So vaccines that can be given, that cannot be given. Well, you know about the attenuated vaccines. So these are not okay. So vaccines that are contraindicated. First, there's through that. Firstly, it's BCG, polio, influenza, cholera. So these are how to remember: CIPT. Just remember TIPSI. Can't give them TIPSI. Tuberculosis, influenza, polio, cholera can be given. Vaccines that can be given if CD4 is more than 200, just like MMR, varicella, and yellow fever. Okay, can be given. And vaccines that can be used in all infected patients like virus, B, influenza, Japanese encephalitis, meningococcus, polio, rabies, diphtheria, all these can be given. So now, whole killed organism inactivated can be given. Live attenuated you can't really. So these are live attenuated, right? The circle ones, live attenuated, and then whole killed organism, inactivated organism. These ones can be given. Most of the other types of cholera vaccines are given. Okay, so now HIV complications like Pneumocystis carinii pneumonia, while the other organisms Pneumocystis carinii is now referred to as Pneumocystis jirovecii. The term Pneumocystis carinii is still common in use. It's an unicellular eukaryote, generally classified as a fungus. Some authorities consider it as a protozoa. So the most common opportunity is infection in AIDS. All other patients with CD4 less than 200 should receive PCV prophylaxis. So what do you do? Basically, features are dyspnea, dry cough, fever, high, very few such as signs. Extrapulmonary manifestation can be hepatosplenomegaly, lymphadenopathy, choroid lesion, and then the treatment is cotrimoxazole, trimethoprim with sulfamethoxazole. Okay. Diarrhea in AIDS. So we're coming to the end nearly. Diarrhea in AIDS is common in patients with HIV. This may be due to the effects of virus itself, HIV enteritis, or opportunistic infection, or HIV medication. Possible infections causes are Cryptosporidium plus other protozoa most common. Cytomegalovirus as well, Mycobacterium avium intercellular Giardia as well. So this is very important, I'm telling you. Okay, most common Cryptosporidium, most common infective cause of diarrhea in HIV. It's a intracellular protozoan which has been an incubation period of 7 days. Presentation is variable from mild to severe diarrhea. A modified serum stain, acid fast stain of the stool may reveal the characteristic red cyst of Cryptosporidium. So red cyst in stool. Remember that, red cyst in stool. Of Cryptosporidium. Treatment is difficult, with the mainstay of management being supportive. Nitazoxanide is licensed in the USA for incompetent patients. So this is the one actually now being used. Next is as well another cause can be cytomegalovirus or Mycobacterium avium intercellular. An atypical mycobacteria seen with CD4 count is below 50. So below 50, you can see this as well. Typical features include fever, sweats, abdomen. This was not there here. It's just diarrhea. Severe sweat, abdominal pain, and diarrhea. There may be hepatomegaly. Urine GLFT is exacerbated by blood culture and done bone marrow examination. Management is with this is Mycobacterium. So rifampicin, ethambutol, clarithromycin. So less than 50 is the charm here. And some systemic features are also there which may make you think about it. Okay, pregnancy. With the increased incidence of HIV infection among the heterosexual population, there are an increasing number of HIV positive women giving birth in the UK. In London, the incidence may be as high as 0.4% of pregnant women. The aim of treating HIV positive women during pregnancy is to minimize harm to both mother and fetus and decrease the chance of vertical transmission. So what do you do for that? Factors which decrease vertical transmission from 25 to 2%. Screening. So what you can do is just do screening. NICE recommends offering HIV screen to all pregnant women. And maternal viral load is the most predictive factor for VIP question. Maternal viral load is the most predictive factor for perinatal HIV transmission. So check the viral load. Higher HIV viral load is associated with a greater risk of perinatal transmission. However, transmission may occur with any viral load even when the systemic plasma viral load is beneath the level of detection. So it can actually cross, but it's the most predictive factor. So it's a question, what do you do for that? Maternal antiretroviral therapy. Zidovudin, that is the first one, that is the NRTI, zidovudin, reduce the risk of transmission to less than 5%. So that's good. If women are not currently taking antiretroviral therapy, it's usually comments between 28 and 32 weeks of gestation and should be continued interpartum. So start at 28 to 30 weeks. So almost near the end, 20 to 32 weeks you start Zidovudin. So Zidovudin, there'll be anemia, myopathy, black nails as side effect. Anemia, myopathy, black nails. As side effect. Okay. So it starts from 28 and till 32 weeks of gestation and should be continued interpartum. So mode of delivery should be cesarean section, 50% reduction of so mode of cesarean 50% reduction in risk compared to NVD. So there's lesser risk with cesarean section. Zero-wound infusion should be started 4 hours before beginning the cesarean section. So before the surgery, 4 hours of the surgery, start the zero-wound infusion. Okay. Neonatal antiretroviral therapy is also needed. Infant feeding, bottle feeding in the UK, all should be advised not to breastfeed. So no breastfeeding for HIV. Okay, next is Kaposi sarcoma. We're nearing the end of infectious disease. So what is Kaposi sarcoma? Caused by HHV8, human herpes virus 8, present as purple papules. As you know that Kaposi is an aunt who wears purple dress, purple papules, or plaques on the skin or mucosa, example gastrointestinal and respiratory tract. Skin lesions may later ulcerate. There can be ulcer formation. Respiratory involvement may cause massive hemoptysis and pleural effusion. Radiotherapy and resection. So you give the treatment of RR, radiotherapy and resection. So skin, respiratory involvement, or the GI drug involvement, HHV8, radiotherapy and resection. Immune reconstitution uveitis occurs in AIDS in response to immune system recovery. There's a granulomatous uveitis that leads to reduced vision and eye discoloration. So investigation of chest X-ray typically shows bilateral interstitial pulmonary infiltrates. Okay, this one occurs in AIDS in response to immune system recovery. Okay, chest X-ray typically shows. So which one? This Kaposi sarcoma? Oh, you mean this one? Okay, so I think this one is PCP. Okay. Okay, chest X-ray shows typically shows bilateral interstitial pneumonia, pulmonary infiltrates, but can present with other extra findings like global consolidation may be normal, exercise-induced desaturation. So sorry, this is for Kaposi sarcoma as well. Sputum often fails to show PCP. Bronchial lavage often needed to demonstrate PCP. Silver stain in PCP. Pneumocystis cardiac pneumonia, so silver stain. So, and management can be cotramoxazole, as we've seen before. Ivermectin in severe cases, and this is for PCP again. Steroids if hypoxic, 9.3 kPa, then steroid decrease the risk of respiratory failure by 50% and durable death by a third. The most common cause of biliary in patients with HIV is sclerosing cholangitis, as we started before, due to infections such as CMV, cryptosporidium, and microsporidia. Pancreatitis in the context of HIV infection may be secondary to antiretroviral treatment associated with tetanosine or opportunistic infection like CMV. And immune reconstitution, inflammatory syndrome, IRIS. IRIS is an exaggerated immune response to a variety of pathogens in response to antiretroviral therapy, mediated recovery of the immune system in HIV patients. IRIS kills up to 1/3 of patient or 50% up to 54% of patient develop IRIS within the first month of antiretroviral therapy. So start of antiretroviral therapy, we may develop IRIS. Okay. The immunopathogenesis remains poorly understood, but clinical and pathological observations such as the mechanism of virus may vary according to the target antigen. RS commonly results in cryptococcal meningitis, so it's dangerous. CMRS may be the result of an unbalanced recovery of the immune system leading to an inappropriate immune response to persisting C. Neoformans, fragments and proteins that are slowly cleared from the body over months. TB is the second most common IRIS-associated disease in unselected patients of um, unselected patients studies. Unselected studies of patients starting AIT accounting for 20% of reported IRIS cases overall, and is the commonest in resource limited. So TB-associated IRIS may present in two ways: paradoxical worsening of symptoms of known disease either at new body site or at the original body site, or an unmasking of focal Mycobacterium TB infection, in which infection was not clinically apparent prior to ART, but presents fluidly during ART. Okay, so that's it for infectious disease.